to you. Hello, Mike.
Alexander, Ali, sorry I'm running late. We haven't had any time shift here in Australia, so apologies. Our daylight saving must be different from the rest of the world, I think, which puts us out an hour. But yeah, so a few of the Australians I told will be logging on in an hour's time. So I'm just going to message them as we go to try to get them to come in earlier. But yeah, we're going to run this session. I'm going to just get going on the presentation, if that's okay. And we've got quite a few people on. Ali, I'm just wondering if there was Dr. Burchuk, Matthew Burchuk's on the chat. If we can get him in on some of this, because he's a regular participant. So get him in and even to speak and answer questions if he's available. And we're going to be voting in the chat box. So Alexander, Ali, Matt, Wendy, if I've got you guys there, if you can let me know how the votes are going, that'd be great. So can you guys see this screen? Is that all working okay?
Not yet here.
Not yet? Okay, one sec.
So brilliant. If you can go.
Alrighty, how's that going?
Perfect.
Yeah, you got it? All right, beautiful. Okay, so we're going to get going on the Royal Rumble, bit of a wrestling match here on a really common pathology. And this is one that I put up on Twitter with a little meme. Someone said that I didn't put just regular old posterolateral fusion on there. And that's partly because I ran out of space, because there are a few more options than this. And so these will be all cases with L4-5 degen spondy. This will be all patients need surgery. They've all maximized their conservative treatment. All options can be considered, even ISPs, if you can justify them, okay? So, you know, if anyone wants to put their hand up and say ISP, we're very happy to hear from them. All right, so this is the case that we were starting with on Twitter, and this is a 65-year-old female who's actually working at quite a high level still, no plans on retirement. She's got quite severe left leg radicular pain, a little bit of claudican symptoms, and she's got associated lower back pain. And her L5 nerve root block helped her leg pain, but not her back pain, and her facet blocks helped her back pain, but not her leg pain. She's I use bone scan spect a fair bit, and she's active across the discs and the facet. The disc at L5S1 and the facets at 4-5. And she's got this degenerative Spondylolisthesis at 4-5, disc degeneration with a slightly kyphotic disc at 5-1, and some disc degeneration at 2-3 as well. So this is her MRI, and this is her erect X-ray. And I've just marked there the differences in the listhesis, which I measured out, and I've also got her parameters on there for the actual degree of slip. So then we heard also on Twitter from Andrew. And he said that this was actually very useful. He didn't necessarily do flexion extension X-rays, and I don't do them either. I find just the difference between the lying and MRI and standing X-rays usually enough for me to make a decision. So I'll go to the panel real quick. Who still does flexion extension X-rays routinely? Matt does them. Ali does them. Alex, no. Does anyone feel really strongly about flexion extension X-rays?
I don't think I feel that as strongly as I think I feel about them. I think I do them because I'm at a fairly traditional place in a lot of ways. I've been trained to do them and I'm young, so I still do them. But I agree. I think there's some of that's probably don't need a lot of it.
Yeah, I mean, I think there can be certain cases where they're really helpful, where there may be some subtle instability and you can't really work out what's going on. But by and large, I don't really use them these days. I actually prefer to spend the money on other investigations. So we're going to try and vote in the chat. So I'll go back and actually this will just have a little sheet there. So we're going to have decompression alone. We're going to have endoscopic decompression, decompression and posterolateral fusion, PLIF with a posterolateral fusion, as it's always done. So an open PLIF, OLIF or a lateral with percutaneous pedicle screws, ALIF or TLIF. And her anatomy is fine for OLIF, for lateral, for ALIF, for TLIF. It's not really an issue, but yeah, she's got a bit of, she's got a bit of sort of encroachment of the vein, but nothing dramatic. So yeah, you can really do any approach that you want. Have a look at the chat.
Mike, may I ask you something?
Yeah.
You are giving us the option decompression alone and endoscopic decompression. Do you think there's a difference?
Look, I think the endoscopic surgeons may say that it's truly a anatomy sparing approach, and that the risk of instability or gross instability anyway after that would be a lot less. I think a lot of people that do decompressions alone for this these days do things like spinous process sparing techniques. So very few people would do a traditional laminectomy, take the entire spinous process wide facetectomy at this level alone. I think that that's sort of disappeared gradually, but I'm sure in some parts of the world it is still done.
And do you think, as an orthopedic surgeon, that the interlaminar tissue, the ligaments, are important in this patient population, in the elderly?
Look, I don't know if the interlaminar ligaments are that important in terms of stability. I think it's probably more the inter and supraspinous ligaments and the integrity of the spinous process and the facet joints. It's more important if you're plane. But so I personally do. I'm not an endoscopic surgeon. I do a spinous process sparing approach when I do decompress these cases. I mean, what do you do? I know you do endoscopic work. Do you do endoscopic decompression for these, or?
No, I'm endoscopic, just herniated discs, not stenosis. This is the next level, maybe in some years, but at the moment not. So in the chat box, Mike, when we see that Ali took over the Scandinavian way with decompression alone, if the patient is willing to come back for fusion in a second surgery. And then you mentioned online too that you do a lot of decompression only.
So I felt this patient was a really functional individual, and we got a whole bunch of different responses when we put this up on Twitter and LinkedIn. So Dr. Dahl was here. He wants to do a T-lift. He sent him an example. Looks beautiful. MIS T-lift. We've got Dr. Bahesa. He wanted to do a minimal or a micro decompression, basically. We've got a few others. Dr. Rao from Australia. He was going to do a lateral A-lift and O-lift. And Dr. Joachim was going to do a T-lift or decompression if they were sick. I suppose I want to emphasize that this is a highly functional 65-year-old who's got a lot of demands and is still working and wants to be active. And look, the other thing is that their back pain was really troublesome, and the degree of relief that they got of their leg pain from the nerve root block was not enough that they said they'd be able to keep working like that. They weren't really 100% happy with that. So I think that was an important decision maker for me in this case. I think the other thing we also have to look at is what options. So if we get on the chat box and say, if you're going to fuse this patient, and I realize some aren't, are you going to do 4-5 or are you going to do 4-5 and 5-1? Because I think that's a really important decision-making thing as well. And the esteemed Koi Tan, part of the faculty, has been fairly definitive on this. If you can see that message there. He has a strong opinion, which is good. That's what we want. This is what we're here for today.
Mike, this is Ali. Yeah. Can I ask a quick question?
Of course.
So you mentioned something in the beginning that I'm trying to get better at, which is assessing how the response to certain types of injections affects my treatment plan. You mentioned facet blocks. And so let me ask you this, because so obviously it seems you're very experienced with it. If you have a patient that responds in terms of back pain significantly to a facet block, is it in your experience that they're more likely to benefit from a fusion? Is there strong concordance between response to a facet block and a fusion?
Yeah, look, I believe there is. And I do my facet blocks usually just sort of on the lateral aspect of the capsule and try to pick up the nerve to determine if the nerve supply to the facet joint. to determine if it is indeed the facet joint driving the pain or not. Yeah, I think if you inject cortisone in the local area, there's always this local absorption through the bloodstream and other things, so it can be a bit confounding sometimes. So I just find injecting it a bit more lateral on the capsule and where the medial branch is can be helpful for diagnosis. Absolutely. I don't think it's 100%. I put it together with everything else, the bone scan, the mechanical symptoms, but for this patient in particular, it really helped me because, as we know, a lot of patients with neural compression have claudican type or radicular back pain as well. You know, back pain occurs with disc herniation. It occurs with stenosis. I'm trying to work out if just relieving that stenosis is going to help the back pain, or if I do need to take that next step. Alrighty, so Alex, if you could look at the chat box, is it most people just treating 4-5, or are people going 4-5?
Clear that the world is divided into A and B. So
yeah,
Jeremy
okay.
Steinberger from New York, he says a B, as in back to work, and Matthew, who is online here, says A as in all day. So it's I can't answer the question, the chat box.
No, that's okay. There's a variety of views there, obviously. All right. Look, I mean, Matthew Birchuk's on today, and he's a regular contributor. I was going to see what does Matthew want to do? Because I don't know if we can unmute him or bring him in. Yeah.
Can you hear me?
Absolutely.
Oh, perfect. So, to me, this is like a bread and butter spine case. And these patients are usually not professional athletes. And so, most of them, while they're active, they're not like 20-year-olds. And so, the focus should always be on where the stenosis is. As far as if there's a slip with there being any disc space left, I think doing a decompression without a fusion is doomed to failure. I think Kurtz and Herkowitz kind of proved that years ago. And as far as the amount of surgery, I would go where the money is, which is L4-5. It almost looks like that anatomy. It'd be interesting to see some type of good AP to see if that anatomy might not even be transitional at L5-S1, because it looks like kind of a rudimentary disc, in which case
really
there
good
would
point. It isn't.
no need to do anything at 5-1. The other thing is I'm still not opposed to doing posterolateral fusions. I think in patients that you should try and, while I am a believer in direct decompression primarily, I think that you should always be mindful of 65-year-old dura and try and retract it as little as possible. And so, doing a good posterolateral fusion produces consistently excellent results. As far as doing inner body work, I think that's where the value of the flexion extension films come in. If they do have significant motion, then I think having some kind of inner body support will help, whether you do that through a PLIF, T-LIF, O-LIF, A-LIF, D-LIF, or whatever kind of, if you like, is dealer's choice. But the idea is to focus on where the pathology is, which is L4-5. And certainly, for people who have been doing spine surgery long enough, trying to do surgery to address their back pain primarily is going to fail more often than not. So that's my gig. Thank you for letting me contribute.
Oh, Matthew, I completely agree with most of those points. I suppose what I will say is I'm always on the lookout for transitional level. L5-S1 here is not transitional. It definitely was once a functionally mobile level.
Yeah, what you can say though, what you can say is that the disc is so collapsed that level is stable, and it's certainly unlikely that it's going to move even if you don't include it in the fusion. And it's also kind of deep, and it seems like it's well below the top of the iliac crest. So I think that the chances of L5 giving you problems down the line are relatively small.
Absolutely fair. Is there anyone else who wants to sort of?
My concerns are if you would have flexion extension X-rays, you could see what level is doing the most range of motion. And I think that L4-5 will be the biggest range of motion. When you fuse L4-5, then 3-4 will be the second. 2-3 is narrow, 5-1 is narrow. So the more you do, the more you put the forces on L3-4. And so my concerns are between decompression only and TLIF L4-5. And it depends maybe in this case, I would order a flexion extension to have a look. What do I steal this patient when I fuse L4-5?
Absolutely. There's so many different ways of doing this. And yeah, Matthew said it's a routine case, but I think we've all got our own ideas. I had a long discussion with this patient. For me, personally, this was either a decompression alone or a 2-level fusion. I didn't think that a single level fusion was the right thing to do here, purely because I was worried about the kyphotic degeneration of 5-1. The back pain component recognized it's not her main complaint, but she still wants it dealt with. And that disc was hot on bone scan as well. So this is what I ended up doing. These are pre and post-op parameters. So she ended up with a double level ALIF, and at 4-5 and at 5-1 to some extent, at 4-5, I completely take down the PLL. So I get rid of all of that pseudo disc bulge. So I'm basically doing an anterior, like ACDF type decompression through 4-5. And then she's got cement augmented MIS pedicle screws with a little facetectomy at the back. And I've improved her parameters a little bit, just put her back. I mean, she wasn't disastrous beforehand, which is why I chose this case. And what the interesting thing is, I've been following her up now for 2 years. Her pain scores are all much improved. This is her CT. She's rock solid with allograft and titanium cages. And, when we go back to Coy and Dr. Burns as well on here, so I've got a pre-op and post-op scans. It's part of an ongoing study. So she has not had a posterior decompression. And you can see the canal remodel on this. And so this is a 12-month, and she'll get a 24-month one probably next month as part of an ongoing follow-up. So I realize this does not work all the time, but I think we're getting increasing data that it probably works about 95% of the time. If you choose to fuse, you don't necessarily have to go to the back and see, that old duro manipulate it too much. So I don't know what other people think of the indirect decompression. Does anyone want to chime in and say they're a believer or talk against it? Or I think Mike Galgano was saying, how do you choose them? And I think that's always a really tough question. What's your thoughts?
Mike, what I'm more interested is, when did you start with indirect decompression? Did you start with direct and then you switched your routine to indirect, or were you taught in your training that indirect is working? Because the concept is not so old.
Yeah, I mean, indirect decompression probably in some respect started back with Wiltsey, when he used to do uninstrumented posterolateral fusions without taking the whole lamina off, at 5-1 for spondylolisthesis. And patients would get better through stability, and the foramen would remodel if they're solidly fused. And I think the same thing happens here. It certainly wasn't a big part of my initial training. As I've done a number of revision cases over the years, I've realized that not having to go back in, particularly revision setting, and reoperate on very scarred dura is a big advantage in my orthopedic hands. And so a big cage with a solid fusion, you just get that CSF pulsation and things remodel. It doesn't happen straight away, but we're getting 12 and 24-month scans at the moment. We've got over 25 patients enrolled so far. So I'll let you know, we'll have some good data for you. I think a good point on, if you're going to choose to do this, is the real locked facets on a CT scan that are complete bone. They're not good ones for this technique. But aside from those, which are fairly rare, most of it's a mix of a bit of bony hypertrophy and ligamentum hypertrophy. Most people do respond pretty well to this. So yeah, I got a bit of support from McCoy and Kevin Burns, but a whole bunch of different ways, as we know, which is why we're discussing this today. So I'm going to roll on to the next case. This is a different patient, okay? So this is a 74-year-old female, and she's got lower back pain at 7 out of 10. She's got leg pain at 8 out of 10. So it's a real mix, and both symptoms. She's had short-term relief of really both rounds of symptoms from facet blocks and epidural steroid injections. So I didn't order her facet blocks, and she had them direct intra-articular, but probably a bit of cortisone going in the local area. So you can see 3-4, she's got some central stenosis, bit of CSF there still, quite a bad facet arthropathy. And at 4-5, she's really stenotic, central lateral recess, and even out to the foramen. 4-5 obviously got a reasonable spondy. It's collapsed disc though, not that mobile, and her bone scan with SPECT shows a facet arthropathy, and that facet arthropathy is at 3-4. So she's got a degree of that as well. She's a slightly bigger lady, BMI is 35. and she's got ischemic heart disease. She's got a very limited window off her anticoagulation. So the cardiologist said to us, look, really as short as possible would be great. All right, so that's the situation we're in. So again, we've got the options, voting in chat. This time I've thought, well, probably we don't need to treat anything other than 4-5 and maybe 3-4. So what you're going to do? So her anatomy is pretty good for either an A-lift or a lateral or an O-lift there. How's the chat looking? What do we got?
I think the chat needs some time.
They're rolling
it's a harder question.
Okay.
The first one was only L4-5. Yeah. Now you have to consider what to do with 3-4. This is two level, so we need double of the amount of time.
It is harder.
You know, the Scandinavian would always say decompression alone. It's very easy for them. They have one algorithm when to do a fusion, rarely in the first surgery. But you mentioned that this is a patient who has got relevant comorbidities, and you only want to do one surgery, don't you?
Yeah, one surgery and also limited window of anticoagulation. And so, you know, I mean, that raises a whole discussion about how long you keep people off anticoagulation after even a laminectomy, you know, a decompression procedure. Personally, I like them off a minimum of 48 hours. That's what I like, but you know, that probably applies the same for minimally invasive fusion techniques as well. All right, got to roll on. Ooh, I won't go too far yet. What do we got in the chat?
So some say really decompression and posterolateral fusion 2-level. Yep. One colleague says L4-5. I think he wants to look what happens with 3-4 when 4-5 is solved and reduced. It's hard. We have no consensus. And L3S1 is also an option to do a 3-level fusion to go to the sacrum.
Yeah, that is another option. Number 3, doing more. Look, this is a classic clinic patient, though. I think we see these all the time. You know, primary problems at one level, but there's a hint or at least a moderate problem at another level. You're pretty sure it's not driving the problem. But if you just fuse L4-5, the question I have is how quickly does 3-4 become symptomatic? Yeah. You know, if you're going to decompress, you can do both, no problems. But, you know, what instability are you going to drive after that? And are you going to solve the patient's back pain? And that's a big uncertainty to me. Look, I mean, this patient, we discussed again all the options, and I'm certainly not trying to push the patients one way or another. When I talk about decompression in DS, I do quote that prior, I think it was a Swedish study that showed there's about a 20% conversion rate to fusion from patients that have it done. And that was in a patient group that was mainly leg and claudican symptoms, remembering that. So in the end, for this patient, I ended up choosing fusion. I wanted to do something really minimally invasive for her with her comorbidities. I wanted to stay away from A-lift, which got a lot of calcification anteriorly. So I did a 2-level expandable lateral. We've got her solid at 6 months. Her alignment's okay. And we've got a partial reduction at 4-5 with expansion of that space and foraminal height. And she'll be due for her follow-up scan soon. So that's her. All right, we've got another one. There are more. Lots of these cases, just like our clinics. So this is a 75-year-old lady who is medically reasonably robust. Oh, yeah.
Sorry to interrupt. Sorry, can you just discuss your choice of biologic and graft material when you're doing these interbodies?
Of course. So in Australia, we used to be able to use BMP as a sort of off-label use, but it's been banned by our FDA equivalent, essentially. And now you can only get it in extreme revision cases with a lot of paperwork. So this patient had a allograft, bone chips with some putty. That's basically a bit like a DBM or DBX. And so I use a mix of bone chips in the cage with this putty. And then when I put these minimally invasive cages in, or even an ALIF cage, a little trick I do is I wrap the cage in a single layer of Surgicel gauze, which kind of stops the graft material coming out when you're hammering them in. Because you can use the shims or other things, but I just find they're not that effective. A single layer of Surgicel gauze that takes in a bit of blood and just dissolves away is absolutely perfect for retaining graft. Even on an expandable cage, we tested the mechanism to still break it quite easily once it's inside. So this is, just pure allograft that's enhanced with some DBM. And look, they claim there's a certain amount of natural BMPs within this. And at 6 months, I think it's a pretty good result in an elderly patient. We've certainly been watching this very closely because they took BMP really away from us for routine use about 2.5 years ago. So we've been watching it really closely since then.
And Mike, may I ask you, are you happy with the design of the cages in a concave end plate? L4-5 fits wonderful. And then the concavity of the end plate L3, do you have concerns, or do you just think the end plates, the apophyseal region has to be strong and solid for a good fusion?
Yeah, I mean, I think this patient's integrated laterally into the each edge where it comes down there. But I think that, and the facets actually fused at the back. I should have shown that. But the look, this cage could be better in terms of that design, and it's probably needs to just increase the range, and they need to have a domed one for this type of, like an ACDF cage, right? You've got the flat ones, you've got the domed ones. Most of us in what we use. So yeah, I do think they need some better opposition. I like the expandables in elderly patients with potential osteoporosis because they're really gentle. Instead of hammering a trial across, you just get the smallest trial across. You often go up one size, and then you are you're on, and you're just gently winding it up. I've only had one cage of this type back out a little bit. I haven't had any collapse yet. I'm waiting. It might happen. But so far, they've been pretty good. Ooh, all right, I'm going to move along. We've got another case. This is, as I promised, all L4-5. So this lady has mainly leg pain and claudication, and she's claudicant at 20 meters. She's a pretty fit and robust 75-year-old female. She does have some back pain, but that's about 2 out of 10. Sorry, playing that over. But she has a BMI 31. So just a little overweight. She's already been advised by another surgeon that she needs a TLIF. Okay, so she's already come to me having had an opinion from somewhere else she needs a TLIF, but she's heard bad things about fusion. Your family members have had fusions for degenerative lower back pain, for workers' compensation injuries in the 1990s. So you can imagine how that went. Look, that's where she's up to in her thought process. These are her plain radiographs, and this is a case I've got a little bit of follow-up on. So this was back in 2014. She first came to me. Let's go to the voting. Before we do that, I'm just going to show you these scans. So lying CT, she's got 2 millimeters of anterolisthesis. She's got a degenerate disc with gas in it. She's got 6 millimeters of listhesis on the erect X-ray. And the MRI shows not only stenosis, but a reasonable sized disc protrusion behind the L4-5 body with a little facet joint effusion here. I don't think it's a big facet effusion, but she's certainly got a little bit of effusion in the facet joints. I'm going to see Ali. I'm going to pick on Ali and see, does an effusion in the facet joints change your treatment?
What was that question?
Sorry, Ali, I'm going to say, does an effusion, so a bit of fluid in those facet joints, change your treatment?
Yeah, that's a good question, Mike. We definitely look at that. I look at that in terms of facet arthropathy. That's an indirect sign that there is significant facet arthropathy, and they're potentially more likely to slip and slide if I'm going to do a medial fascectomy or decompression alone. Does that alone convince me or sway me to change from a decompression to a fusion? I don't think so. I think I'll go primarily by the symptoms and the degree of listhesis. So if the patient's symptoms, I believe, were primarily leg, not so much back, despite that fluid, I probably would still offer a decompression only.
Yeah, decompression only. All right.
The question is,
Alex,
do we see here a facet osteoarthritis, or do we see a degenerative disc disease? Is it the disc or the facet in your consideration? What is the leading problem? Are you able to, from the symptoms and the clinical examination, to identify the disc or the facet joints?
Yeah, so she's actually, I think she's been claudicant for quite some time, and the radiculopathy has also then got her as well. So I suspect that this is a chronic disc process, but there may be a little acute component of extrusion there behind the body. And that facet arthropathy with the lateral recess stenosis has clearly been there for a very long time as well. So, look, I think it's it's really hard to know. And at what point does the disc fail because the facets are arthritic, or is this a primary disc failure problem with more stress on the facet? And that's the other huge argument in DS, is we still don't know that, right? we don't know what causes this problem and what came first. And yeah, I've got theories about the role of the anterior abdominal wall and the stability of this level. I think that's really important and is often underrated. But there are, yeah, long and short, Alex, I don't know. I don't know.
Sometimes these patients come to me with this similar situation, and then they say they have had zero back pain until 1 week or 1 month ago earlier. So they were living with this fluid in the facets and the slip for perhaps years, and then the herniated disc is the new problem. And this is, for me, is hard because I've seen a lot of recurrent herniated disc if you only do discectomy, and I'm really afraid of these facet joints. And when I see this MRI, I also always inform about the option to fuse. It's hard. It's not an easy case. I thought it was an easy case, but then the MRI shows it's a hard case as well.
Yeah, the question is, do we overthink it? You know, do the you know, some of the Swedish surgeons have it right in that you just decompress everyone and then see how they go? I mean, that's where, you know, their registry data is leaning towards that approach, which is a fascinating one. So yeah, we'll get some voting going if people are still in the mood for putting forward what they're going to do here. You know, this is a situation where I think, you know, we sometimes also have to be guided by patients when, you know, we try to make individualized decisions, and a patient's come to you saying they're really worried about a fusion, and you still push them to a fusion if something goes wrong. You know, that's may not end happily.
So in the chat box, Matthew has written that a slip from 4 millimeters, then he would tend to a fusion. Maybe he's able to tell us why it's 4 millimeters, not 5 or not 3. Is this is there a reason why it's 4?
You know, a lot of the insurance companies in the United States, if you want to demonstrate instability of a slip, you have to have at least 4 millimeters of motion to get it approved. And to me, the fact that there is 4 millimeters of motion, once you remove any of the posterior supporting structures, including the facet joints and the interspinous ligaments, not to mention that there's a large extruded central disc herniation, you know, the chance of her slipping additionally after surgery, I think, are really high, even though the L5 supra end plate is fairly flat and the disc is fairly degenerated. But my concern is that she would eventually need something else done. However, if she refuses to have a fusion done, then I would do a laminectomy, but clearly tell her my concerns about that having problems long term.
Yeah, and do you think when you see the fatty tissue, the obesity of the patient, is this obesity for you a reason to fuse or not to fuse?
Well, there's no question that if she's got a big belly kind of pulling her spine forward, that just increases the chance of her slipping post-op if she just has decompression. So that would be another reason why I would lean towards recommend a fusion. And then I would also think FlexX, well, we got the FlexX fusion, sorry. So to me, you know, it's really a sales pitch issue here in terms of what the patient is willing to have. If you want to take a hard line and say, well, listen, you need a fusion. And if you don't have that, you should find somebody else to do your surgery. Or, you know, if you want to kind of consider the patient more as a customer that you want to make the sale on, you tell them the decompression to the case, realizing and telling them up front that there's a chance that it could fail. That's where the kind of the art of spine surgery comes in.
That's a really good point, Matthew. It is a real art getting these patients, you know, and counseling them and working out what is best for them. Alexander was making a great point about adiposity or fatty deposition. And, you know, there is some data out there that I've seen showing assessment of the multifidus in particular, so the paraspinal musculature, and how patients go after a laminectomy. And there is a small publication I've seen showing that if that's sort of really terrible musculature there, patients do horribly after laminectomies, you know, no matter how good the decompression looks on an MRI afterwards. And so I think we also have to assess the whole patient's soft tissue envelope. And Matthew was mentioning that with the sort of the dragging forward of the abdomen. And I think that's an important decision-making factor. Yeah.
So Mike, it's between A and C. So many say decompression. Some would like to add a posterolateral fusion. Half A, half C.
Okay. Well, that's just me pointing out where the iliac vein is there, creeping across under the artery. So for me, that made this a little more challenging if I was thinking about doing an O-lift. A-lift probably be able to deal with that in an elderly patient, but it's still risky. And look, this is her a bit of the Twitter chat and a note also from her family member. Look, Clemens Weber was on. You roped him in, Alexander, and saying that the implant mafia were going to get him, so he may not join us. Look, as part of the potential implant mafia, I just want to declare that I did a decompression alone in this patient, because that's what she wanted. But I also thought it was entirely reasonable. And like Matthew said, I warned her that there was probably about a 25-30% chance at least of conversion to fusion. She was really happy. So I got this note after a year, and the leg pain had gone, and she was ambulant and mobile. So it all went well. And then this is back in 2014, 7 years later, she's come back, which is fascinating. So it gave me an opportunity to rescan her. I didn't have a clinical indication to do so before. And her symptoms this time were localized to the thigh, mainly radiculopathy, L2 plus minus L3. So she's got some 2-3 stenosis. So I'm going to treat that. And I've done an injection so far. She hasn't had more surgery yet. But this shows the kind of natural history of this decompressed DS. And I think it's fascinating because when I look at that CT scan at the top, I reckon she may be auto-fused those facet joints like that. And I didn't go out to fuse at all. You can see I kept my decompression, you know, fairly midline. I've retained a bit of spinous process, and most of the facet has been retained. And I didn't graft or anything like that. So she's gone on to more of a natural fusion there at that level and stability. And she's done quite well from that, which is I find fascinating. And I do wonder if a number of these patients in the Swedish trials that get better do actually just auto-fuse from the surgical process.
You will get the Nobel Prize for spinal surgery this year about this case. It's good. It's nice.
Hey, Mike, do you ever get any letters from patients that aren't happy?
They write Google reviews, Matt. They're worse. They write public Google or Facebook reviews.
Mike, as you know, in the US, those are not called letters. Those are called something else that get to your office through a law office.
I think it's interesting. I started in neurosurgery, and there was no 20 years ago, and there were no colleagues who were really experienced in fusing the spine. And then I went to orthopedics, and my teacher he really fused every slipped vertebra, and he said it's instability. They come back later, and this was like 10, 15 years ago. And I think it is so hard. Every spine surgeon makes his own experiences. And I think we have to keep them in mind, and we have to collect them. And when we are unsure whether to fuse or not to fuse, sometimes it's good to read these cards and remember that it works without implants.
Yeah, absolutely. All right, so that was her. So we may have to address 2-3 this year, but she's had an injection. We're seeing how she goes at the moment. So We did get on Twitter the Nordston study group, very prestigious study group, responding to, and this was to the first case I put up, and they recommended decompression for that. And then when you go to their paper, and I think every spine surgeon should read this paper, because this is a matched randomized trial on 285 patients on DS with 4-5 alone. So they're very specific, just treating 4-5. I find a lot of these patients have more problems than just 4-5. So they've done a great job just isolating these patients. But it's a fascinating paper, and I think it shows pretty good results for sort of what they call, I think, a micro decompression. Not an endoscopic, but at least a spinous process sparing and facet sparing decompression. So it's definitely worth a read if you haven't seen this publication from 2021 on the JAMA Open Network. All right, I got one more quick case. Sorry, I was running late. I'll go through this really quickly. So this is a 54-year-old female who comes into my office with an MRI. She got lower back pain 7 out of 10, leg pain 8 out of 10. The worst on the left side, an L5 distribution. She's got no claudican symptoms. She gets short-term complete relief from facet blocks. And she's got, she had also some relief, but not complete relief from a L5 selective nerve root block on the left-hand side. The BMI is 31, and this is her MRI. Now, I'm just going to put it out there. This is her MRI. Now, what the Swedes are saying is, and still a lot of surgeons, even in Australia, are pretty conservative. They don't get routine radiographs for a patient like this.
Mike?
Yeah.
Yeah, to me, this is like a perfect case for a D-lift or X-lift and perk screws at 4-5. She's got no real canal narrowing. And if you just stabilize this, she should do great. So this is like the perfect case for somebody who doesn't need a decompression and just needs stabilization. You can see with all the fluid in those set joints set on FlexX films, you know she would move. That, as well as the fact that the disc height is really plump and well maintained. So there's this is like a I think a perfect case for that.
Yeah, Matthew, I tend to agree. I know there are some people out there, even high volume surgeons in my own town, that would not necessarily get erect radiographs for this and may just go after that facet joint cyst on the left, which I presume is causing her left L5 radiculopathy. And look, I don't know, is anyone here just decompression alone for this kind of case? I'll put it up there. These are her films. So if we go back a step, check out the MRI, and then check out the EOS scan. Look at how 4-5 goes. It's a fair difference.
Yeah, those are, Mike, you were asking earlier about fluid in the joints. That's the type of fluid that gets my attention. I mean, that's hard to ignore.
Yeah. I thought it was a nice extreme example, but as I said, I still see cases, plenty of local cases where people do not even get erect radiographs before considering a decompression on a case like this. Having seen that, we're going to go to a vote. I've got just some select images there just to remind everyone. Matthew's given what he would do. Just get the chat working.
So in this case, it's clear if you have to decide DD or osteoarthritis. In this case, you would say osteoarthritis, Mike, or you say both?
I think that this is primary facet osteoarthritis instability. But my theory is that it's primary facet arthritis that causes the problem, even in the DD cases. It's that micro instability in the facets. But can I prove that? Absolutely not.
So we have
got a few
Matthew in the chat box who's saying E, as he mentioned on the microphone. We have got ALIF as well, and we have got TLIF 1 level. We have got, I think the majority is OLIF and ALIF.
OLIF and ALIF, yeah, and I think that's pretty reasonable. So I'll just go through and show you what I did for her. So this is me doing a little bit of prone lateral work here. Her pelvis was low enough for me to get at 4-5, and her psoas was friendly enough. for a transpsoas approach. And this is using a prone position with a lateral retractor with pins. And unfortunately, I don't have any shots right down there, but you can see pretty well down these little spaces. The view is very similar to a lateral. You just need really good light. And that's the cage we got in there. And just a lateral, standard lateral cage. I haven't completely reduced it, but I got most of the way there. And I'm a big fan of cemented screws, and she had maybe some osteoporosis issues, certainly in the family. And so I just cemented in some pedicle screws at the back for her. But I also did an MIS facetectomy at 4-5, just to make sure that fused nicely. And so these are her pre and post films, and we've given her back some of her sagittal balance, I think, and she's got a nice construct, and she's much improved. So yeah, I essentially did a lateral fixation. I'm not convinced that prone lateral is the absolute be all and end all that the marketing people are starting to tell us, but I think it is useful for certain cases. Nice to have in the toolkit. I'm not sure it gave me any more lordosis here than I would have got doing a regular lateral and then flipping, but it certainly, I think it saves you a bit of time. I've never been a huge fan of putting screws in the lateral position. And I do like that with the prone position, you get a bit more postural lordosis, particularly if you leave the legs out flat on the Jackson table. And then the other thing is it makes it really easy to do a facetectomy when you put your screws in. Doing a facetectomy, if you've got the patient in the lateral position, you're putting screws in around the back, I find it's very, very hard. So I was able to do that here and pack the facets with a bit of bone.
So you've chosen an obese patient for a prone DLIF OLIF.
Prone lateral. Yeah.
Was it the first, or did you do several?
No, this was not my
thinner
first
patients?
I'd done about 10 before this.
Okay.
But in that prone position, the abdomen falls away. And so you've just got to deal with the sort of the hips. And I think everything always looks much worse on standing x-rays than how patients are when they lie down in theatre. With the exception of the males who've got a lot of abdominal adiposity, I find they're the hardest ALIF. And, like a woman with a BMI of 35 can be really easy. And a male with a BMI of 35 can be a disaster, or difficult anyway. So, yeah. But this is just a prone lateral I did about 12 months ago. She's doing really well with this, and she's gone on to solidly fuse through there. That CT there is just an initial post-op CT. I just get an implant check CT, low dose on all my post-op patients when I'm doing something new like prone lateral, just to make sure I haven't stuffed something up. It's part of my own learning for the technique.
What would you have done if the iliac crest would be higher or the disc would be lower? Would you still use the same approach? Are you able to curve into 4 or 5?
Well, look, I think if you use navigation, certainly John Ashgar's got a bit on this, you can curve into the 4-5 with an OLIF type, almost an oblique type approach from this prone lateral position. But I just prefer to keep it fairly straight ahead. I'm a very, straightforward kind of person. I can't think of too many funky angles at once. So I like to just go straight for that corridor. Yeah, this is not a good case to do if the anatomy is not favorable. And I don't think that there are a heap of 4-5s that are actually really good for prone lateral. I think 2-3, 3-4, much better, much better. But 4-5 is a bit tough. And look, this patient here, if they had a higher iliac crest, I would have probably done an OLIF and then flipped. She's due for an MRI, I think, this month, just to see if that facet fluid is all resolved. And it'd be nice to show it has, I think. I suspect it has, because she's clinically much better. So yeah, have we got anything on the chat box? Any questions to answer? Because we're running a little behind.
Yeah, from the chat box, there was a question. What about TLIF in this case? Would you think this is an inferior? Is disadvantages? Do you go because OLIF is better, or do you think that TLIF is maybe a wrong decision in this case?
Look, I think a well-done TLIF is often very good for single-level pathology when the patient has reasonable lordosis and doesn't have any sort of creeping towards deformity type problems. So I think a TLIF would have been an absolutely fine option for this patient. I personally have just found a lot of TLIFs get radiculopathy. They spend a bit longer in hospital, and I struggle in the larger patients with the TLIF, particularly MIS TLIF in the bigger patient group. I just find you're looking at a small target at the end of a deep tube. With navigation, it certainly helps that, but I admit that over the last 5 years, I've only done about 4 TLIFs a year. And the years before that, I was doing 40 to 50. So I changed my practice a lot. And that was partly because of subsidence in the peak TLIF cages. I just found that you get lordosis on table. It wasn't maintained at follow-up. And most patients would still fuse, but they'd subside during the fusion process. And I hated that. You achieved the goal on the table. And then, you get follow-up x-ray. You're sure the patient's probably feeling okay, but it never sat well with me, and it meant I really switched around. I'd already done some ALIF and lateral then, but I really switched to making my practice based on bigger cages than the TLIF cage. I'm excited by some of the new cages, the expandable TLIFs that expand medially laterally as well as up down, and whether those bigger footprint cages can give some better results. So there's lots of different things out there, but I still do the odd TLIF, but not a heap. I've actually got one next week. But yeah.
I find this X-ray very interesting because you are doing really convergent pedicle screws, and I switched to cortical bone trajectory, especially in patients with slip vertebra, because the screws have got a better quality, better strength, better pull-out strength. And so it's nice. Do you think there is a difference between the type and the design of the screws for the MIS from posterior, or can you use any system? Did you think monoaxial could be more stable? Do you see a loss of the reduction of the slip? What are your thinking about the implants from posterior?
Yeah, I mean, I try for a triangulation because it just makes more sense biomechanically. It also keeps the cranial screws off the facet joint. And to me, that's really important, right? You don't want your screw leaning right up against that facet joint, because we know from a biomechanics perspective, that's probably bad for the adjacent segment. And then, look, that's where actually doing a little bit of robotics helped me a lot. Just that initial nasal renaissance I had for a while. The planning of the skin incisions for the perk screws with the robot. This was one was just done on fluoro, but it showed me that I was probably starting too medially for my percutaneous screws, and I needed to go more laterally to get perfect trajectories and really keep that head of the screw off the facet joint. I don't know what others think about that, but I find Matt Goodwin's in. He's gonna.
Oh yeah, I like that point. Yeah, no, I was gonna say I love the trajectory. I love that you're off the set that's above. I feel like so many times we see the especially as people move to doing more perk, they've just blown up the set above, and I know we've all revised several of those and they fail above. And how much does it contribute? I don't know, but I agree. Keeping that thing off the set above probably makes sense. I think this looks really good. I also think this session is great because you put up these cases and I think, oh, that's a 3 to 5 from the back, and then we get 1,000 answers. It's kind of amazing, and it certainly stretches how you think about some of these. So nice job. It's really good.
Yeah. Thanks, Matt. All right. I'm sorry I was running late. We probably should start moving towards wrapping it up. Are there any other comments from the chat boxes or the faculty things we should be addressing? I think we're never going to come to consensus. And I think one of the things here is that we should find something we do well and probably keep doing it for the majority of cases, but it is not nice to have different tools in the kit to deal with different pathology and individual patient variations. So I think that's where also working with friends is helpful. You might be an excellent micro decompression surgeon, but might be a bit worried about a patient that's bigger like this, that may be a challenging fusion approach. So I think it's always it's good to have friends you can call on. It's good to have different options, I think, as well.
That was great, Mike. Thank you so much. Those were great cases, and I just put my 2 cents in the chat box that you've got to be just flexible enough to be able to offer all of these, whether it's decompression or fusion, 1 or 2 levels. And I don't know who's winning and who's losing, but we certainly have a lot of great.
Yeah.
Speaking of spine injuries, but no, thanks so much. That was a great session, and Alex and Matt and everybody else for moderating and answering some questions. Thanks to Dr. Burchick for his participation and all the participants. So without further ado, yeah, we are a few minutes past, and we will see everybody next Thursday in 1 week. Dr. Gibbs, Wendy Gibbs, our neuroradiologist, will be showcasing some challenging cases along with the faculty here. So thanks, everyone, and we'll see you next week.
Thanks, Ali. Thanks, Alex. Thanks, Matt. Thanks, everyone.